Hello, my name's Olivia. I'm known as Olivia K on Facebook, Ollie K on Instagram, and WarmYam9000. The reason I sound all weird because I am going to go to bed in a few, but I want to make this quick last installment of the maternity newborn. This isn't the last video, but it's like the part 3 because I added it. It was originally going to be like a part 2 to divide the video up with the postpartum and fetal arrhythmias. So I'm also going to add complications for labor. So that was like the bonus. So this will be like part 3 and the final part, and then I move on to newborn next week. So that's what I'm going to talk about. But yeah, I primarily go over nursing related materials. That's going to help you for your next attempt at the NCLEX. It's going to help you with nursing school, like permanent information that's going to be helpful too. So that's what I mostly do. I have a playlist for those who are interested in going to nursing school. The T's, I didn't make those videos personally, that's like years ago, but I think the information can still be pertinent to you guys. It's going to be very helpful. And not only that, I do cover documentaries, reality TV shows like Love is Blind. There's a whole playlist on that, and The Ultimatum. I'm going to look into doing the queer edition probably this or next week, depending on how my schedule goes. And then I do opinion pieces, so check those out. And if you want to suggest like a show for me to watch, unless it's not a perfect match, or Love Island, because I think a lot of people cover Love Island. So just suggest a show I can watch, and then I'll give my honest reaction and kind of go from there. But this is my final piece of the 3-part, it's going to be 2, but it's 3 parts for the labor and fetal arrhythmias. But now I'm at the labor complications, which I think it is highly tested, and you will see those in your case studies or drop and drag or the clothes where the drop down menus. So you may see something like that in your Q banks or the NCLEX. So it's good to go over these. But I'm going to start out with fetal distress. So that's abnormal fetal heart rate. So say, like, remember how we went over the fetal arrhythmias? If the fetus, the normal heart rate for the fetus is 110 to 160. So remember I was saying, if the newborn, if the fetus, the heart rate showing over 160, they're probably in a lot of stress, okay, or reduced oxygen. So the intervention, remember I said in the last video, the intervention would be, not last video, I think 2 videos ago, lying. So remember what I talked about with the positions, lay the patient on their left side, push IV fluids, oxygen, notify the provider. So that's what you do. So you want to stop the Pitocin, aka oxytocin, if it's infusing. Sorry, so I'm going to sound all weird because I have the retainer in. So for you guys who are going to be watching in the afternoon, continue maternal vital signs. Check for uterine tachycily. Continue electro-fetal monitoring. So definitely check that. And you may want to consider the vaginal exam so if you see like a cord prolapse or fetal descent, you want to get a tocolis as a trutylene. So that's slowing down the contractions, right? Slowing down the labor. So remember what I said about trutylene? It's like a turbulence in a plane. It's like shaky, but then it eventually calms down once the pilot gets the right footing of the plane. I'm sorry, like I said, I get so scared with flying because of that. But yeah, that's that. All right, so then there's prolonged or arrest labor. So the cervical dilation, so that's having the cervical dilation, or the fetal descent stops. It stops out of nowhere. All right. The intervention would be assess the contraction strength, frequency, and duration. Monitor for the fetal heart rate continuously to see if there's any distress, because it could have the tachycardia, right? Encourage position changes such as walking or encouraging them to be like in an upright position, so where they're walking around. Encourage a patient to empty her bladder every 2 hours. Maintain hydration status. Provide IV fluids as ordered. Provide rest, pain relief, emotion. Because this is stressful, okay? So the magical thing is when you're doing these maternity questions and the mom's psyche is out of whack because she's anxious, what you would do, you would provide emotional support. I'm telling you, that's the best answer you can get. So that's just going to be a tip right there for you guys. I'm sorry, I'm so edgy. Administer oxytocin as prescribed to strain the contractions. Because of course that promotes contractions. That's what the oxytocin is designed to do. You may have to prepare for an amniotomy as ordered. So that means they may have to create and open up the cervix so that the baby can do this, right? But before that happens, you need to check the fetal heart rate before and after the membrane ruptures. So they are artificially doing so. You're going to oh my god, I cannot speak sometimes. Prepare for an operative vaginal birth or C-section, which I couldn't say earlier for some reason. If the labor is not progressing or the fetal distress develops, okay? Precipitous labor, so labor and delivery that occurs in less than 3 hours. So just stay with the patient. So that means it's supposed to occur, right? Stay with the patient, call the provider and the delivery team immediately. Don't ever leave the patient alone. That's the worst thing you can do. Or allow them to walk to the bathroom by himself. Assess fetal heart rate, contractions, cervical dilation, and you want to help encourage them to push. So you see in those medical shows where a mom's pregnant and she's ready to give birth, you want to hold their hands or just provide anything, like anything that's going to help them with the anxiety, because a baby's coming out and it's going to be very stressful. They need somebody at their side, okay? Encourage panting, short breaths to reduce a forceful pushing if possible. Position patient safely. Place a clean towels underneath. So prepare for emergency delivery when that occurs, or neonatal resuscitation. So you may have to do CPR with a newborn, right? Support the baby's head as a crown. Don't ever pull. Please do not pull or attempt to hold the baby while it's in the process of coming out. Don't ever do that. I've never seen that happen. I know in shows they do that because it's for shock value. But in real life, you're not doing that. You are going to assist the baby while she's pushing. After birth, so don't pull unless they're directed, okay? So after birth, you're going to keep the newborn warm and dry because their newborn doesn't have the ability to keep itself warm. It needs intervention. So, and always, if you can, please encourage skin to skin if they're stable. Then you're going to monitor for lacerations during atony and postpartum hemorrhage. I cannot speak for straight. I don't know why. Okay, so this is a start and underline. Please pay attention to this part. Umbilical cord prolapse. The cord is going to slip below the baby, reducing blood flow. So this is an emergency. What do I say all the time? Do not delay treatment. Please, please, please call for help and notify the provider immediately. Please. I cannot stress that enough. So when this happens, you need to put a sterile glove to your hand and you have to insert it inside the vagina, lifting the presenting part of the fetal part of the cord, okay? Don't remove your hands unless you're instructed or directed to, or until the delivery, period. Position the patient knee to chest or Trendelenburg. So I've heard knee to chest many times in different books, but you can also do Trendelenburg, okay? Administer oxygen if the mom's O2 levels are low or per emergency protocol, okay? Give IV fluid bowls as ordered. Continue to monitor fetal heart rates. If the cord is present, you want to cover it with normal saline gauze. Moisten with normal saline. Do not put it back in, ever. No matter what. I don't care what facility you're in, what institution you are, don't push it back in. Don't. This mom's going to be a C-section, likely. Okay? So moving on. Shoulder dystocia. The baby shoulder becomes stuck after the head is delivered. So you're going to call for help and notify the provider immediately, and you're going to perform what's called the McRoberts maneuver. So listen closely, right? So that's a sharply flex the mom's knee towards the abdomen. So I'm going to provide a picture. So she's like, the knee's basically up to the abdomen, the abdominal piece, okay? And then what you do is you're going to apply pressure to help release the shoulder. So please, you want to be there with somebody who knows how to do this procedure, this maneuver, because otherwise you can harm the baby, you can harm the mom. So don't do this unless you know how to do this, unless you've been trained, okay? Prepare for additional provider maneuvers and neonatal resuscitation. Assist with position changes such as hand to knees. So which we're just talking about. Hands and knees. So what we're just talking about now, okay? After birth, assess the newborn for brachial plexus injury or fractured clavicle, okay? Monitor for the mother for lacerations and postpartum hemorrhage. So every single kind of complication, please look out for hemorrhage. And I know we did talk about this in the last video. Never apply fundal pressure because it can worsen the impact. So again, you want to get somebody who knows what they're doing. Don't try to attempt this by yourself unless you've been properly trained. Now we have uterine rupture. Please start to underline this part. The uterus tears, especially with previous uterine scar. This is an emergency. Do not delay treatment. Call the emergency team. Notify the provider immediately, like right now. Stop the oxytocin. Administer oxygen if the mom is hypoxemic, silly, or according to emergency protocol. Maintain or insert 2 large IV bloodlines. Because why? This mom could be lose blood. Hemorrhaging could occur. This is very important. She could get dehydrated and lose a lot of blood. Continue to monitor the fetal heart rate and mom's vital signs. Position mom laterally while preparing for delivery. Obtain ordered lab tests such as CBC, the coagulation. So which will be what? WBC, RBC, HG, HCT. HG and ACT is what they're going to be looking at. Because why? That indicates how much red blood cells they have, how much volume they have in the blood. So they're going to be mostly paying attention to those. All right. So what else do we have here? And type and cross match. This mom may possibly need a blood transfusion. Who freaking knows? This is why this is super important. Go back, if you're not sure about the transfusion piece, go back to my lecture about shocks, so you'll understand. Okay. Prepare for an immediate emergency C-section. So this will be a C-section. It could possibly be a hysterectomy. Okay, monitor for hemorrhage, as I was just saying. So which is why we're looking at what? The type and cross match. Why we need the large bore IVs, because it's going to provide a lot of fluid. So monitor for hemorrhage, shock, or decreased urine output. That's another thing too. Look for decreased urine output. All right, so possible warning signs we have: sudden severe abdominal pain. And like, remember what I said about with the stages of pregnancy? Anytime there's a sudden abdominal pain, don't delay treatment. You need to know about the provider, because this could be a warning sign, right? Abnormal heart rate. Is either like below 110 or above 160. In this case, it would be above 160. vaginal bleeding, loss of fetal station, cessation of contractions, and maternal shock. So listen to this, and I'm going to repeat after me. Please write this down or repeat this part. I don't care. Stop the oxytocin, call for help, stabilize mother, and prepare for immediate surgery, which is going to be C-section. All right, placenta, abruptio, and previa. I think we briefly touched on these already. So the placenta is going to separates way too early, right? There's going to be painful bleeding, and there's going to be rigid abdomen. Blood is dark. Remember I said this, right? So no vaginal exams, although some people say if you know for sure that is it is previa, or not previa, if it is abruptio, then you could possibly do that, but I still say don't do vaginal exams, but go with your policy and what it tells you. Continue. So before I go to that, notify provider and activate emergency response. Please, 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 no vaginal exams, whether it's abruptio or previa. So double check. And I know that NCLEX is a perfect world to want that answer. Continue to monitor the fetal heart rate and contractions, assess for vaginal bleeding, severe abdominal pain or back pain, uterine tenderness, or a firm board-like abdomen, as we just said. Monitor the vitals frequently for hemorrhagic shock. Left side. We want her to be on her left side. Why? Because you can have supine hypertension, and that's bad for her and the baby. That's bad news. We mentioned that before. Okay? Stop the oxytocin if possible. If it's infusing. So just stop it. Okay? Establish 2 large bore IVs, because she's going to need the fluids. Okay? Obtain CBC coagulation studies. Which are they? So that would be the HCTB, ACT, HGB type and cross match, just in case she has shock. Okay? In case she does. For fibrinogen type. Yes, so what I was just saying. Prepare and administer blood products as ordered. And you have to make sure, what did we say? Make sure the blood, it's the right blood type with her, because her and baby could go kaput. You get the wrong one. Provide oxygen to maternal, oxygen saturation provide oxygen if maternal oxygen sat is too low. Monitor for urine output and quantify blood loss. Okay? Then previa. Covers the cervix, causes painless bright red. Alright? Bright red bleeding. So no vaginal exams, like same thing here. I'm going to say no. No matter what the internet tells you, no vaginal exams with this one. Assess the amount and color of the bleeding. Typically is going to be bright red, right? And it's painless. Assess for shock, vital signs, hemorrhage. Continuously monitor fetal heart rate and uterine activity. Place the patient on, and my contacts, I should be able to read this, on pelvic rest. So no vaginal exams, intercourse, or inserting the vagina. So same thing, just like I said with the abruptio, no vaginal exams. I don't care what they say. So large IV access, large bore IV access. Mom could be losing fluid. Obtain CBC coagulation studies, type and cross match, because guess what? The mom could have hemorrhage. Administer corticosteroids if prescribed. So that's the bethmazone that we were talking about. Remember, we said that'll come back. Yeah, so this will be for fetal lung maturity if the baby goes preterm. Rogam, remember what I said. So if the mom is Rh negative and the baby's Rh positive, she's going to need that. And prepare for C-section if the bleeding is pretty heavy, or mom or baby is unstable, or the placenta continues to cover the cervix. So this is the like I saw underline. Never perform digital vaginal exam with suspected placenta previa, because that can cause hemorrhage. So that's why I'm saying, even with the abruptio, don't do that either. Don't. Please don't. Do not. Meconium stain fluid. So remember I mentioned that briefly, but I didn't give it the name. But it's meconium stain fluid. So that would indicate the fetal stress and risk for aspirations. Notify the provider and neonatal CPR team. I don't care. I have these on and I talk all funny. So we want to assess the fluid, color, amount, and thickness. Continue to monitor the fetal heart rate for the stress because the heart rate is likely going to be high. So stop the oxytocin if fetal heart rate is non-reassuring. Reposition mom loudly. I prefer left. Give IV fluid bolus as ordered. Prepare for the neonatal resuscitation equipment and personnel for delivery. After birth, you're going to assess the newborn, the North breathing, heart rate, so respiratory rate, heart rate, muscle tone, and oxygenation. Because we're going to go into Apgar score next. That's going to be next. Begin standard neonatal resuscitation if the newborn is not vigorous or not responding, really. So we went to that. Okay. Chorioamnionitis. So this is an infection that's causing maternal fever. I can't speak, sorry. Uterine tenderness, foul smelling fluid, or fetal tachycardia. You need to notify the provider immediately. So that's to start underline 2. Monitor vitals, especially temperature in this case, because we're talking about an infection brewing. Heart rate, blood pressure. Okay, then continuously monitor the fetal heart rate. So this is so remember I keep saying throughout the video, you're going to have not maternal, neonatal tachycardia. Why am I being all weird? Because it's going to be up. The baby's under stress. Administer prescribed IV fluid. IV fluid. You want to do IV broad spectrum. Because I mentioned before, you don't know what kind of organism can be brewing in there. So you want to get an IV broad, antibiotic broad spectrum, because you want to narrow it down to what kind of infection it is, and it's going to minimize it or maybe kill the organism. You don't know. But that's going to be better than nothing. And you want to do this like now, so don't delay treatment. So IV fluid, antipyretics such as acetaminophen as ordered. Monitor for contractions, the uterine tenderness, the color, and the odor, the amniotic sac fluid. Obtain culture. Culture would be needed because we're talking about an infection here. Lab test without delaying the antibiotics. Period. Do not delay treatment. Prepare to assist for delivery. Infection usually indicates delivery rather than delaying labor. Prepare to I just read that. Limit vaginal examination to reduce further infection risk, which is true. Don't do that. After birth, monitor the mom for sepsis. Very important here because sepsis kills immediately and it's always brewing. Uterine infection and postpartum hemorrhage, period. Ensure the newborn is evaluated for infection and receives antibiotics if needed or as indicated. So last one, another important one, starting on like the final piece I'm going to get into right now. Postpartum hemorrhage, excessive bleeding commonly caused by uterine atony. So which is why I said in my last one, you remember, if it's boggy, it could definitely mean that there's hemorrhage. It's important that the mom even delivers the placenta because that's going to cause hemorrhage. So always call for help. Do not delay treatment. Activate postpartum hemorrhage protocol, because I know there is, because too many women have died because they're not monitoring the bleeding. So this is put in place. Perform firm fundal massage if the uterus is what? Boggy. I mentioned this many times in my last video. Empty the bladder with a catheter if necessary, or you can even do the bedpan. If she's able to pee, you can do the bedpan or toilet her. So just don't make her walk by herself if she's not weak, okay? Whether she's weak or not, you're going to assist her. Establish or maintain 2 large bore IV lines, which is true. Administer oxytocin or rapid IV fluids as ordered. Administer uterotonics as ordered, such as methylogonovin, which I think we mentioned that. So that is going to help. Of course, this is for the hemorrhage. Alrighty? Avoid with hypertension. And the carbopros, avoid with asthma. With misoprostol, it could cause fever and chill. Give tranexamic acid and blood products as ordered. Provide oxygen when hypoxemic and keep the patient warm. Prepare for the balloon tamponade, uterine artery embolization, surgery, or hysterectomy if the bleeding continues. So listen to the 4 T's, okay? Tone, uterine atomy, trauma, that's lacerations or hematoma, tissue, retained placenta, and thrombin clotting disorder. So this is a key for you to also recognize before I end this video. The key clue: boggy uterus. A boggy uterus suggests atony. Firm uterus with continuous bleeding that supports or suggests trauma or laceration. So just remember those. And that'll be it. That's the final video talking about the labor complications. I know this was a lot, so I have to make it like a 3-part kind of series. Next week I'm going to go to newborn. So that the vitals, Apgar score, the the meds you should be getting, and also I believe when you're doing the reflexes. So we'll talk about that too. Anyways, thanks for watching this and putting up with me. I'm sorry, it doesn't help why I have the retainer and I talk all funny. Anyways, have a good night and have a wonderful rest. Well, this afternoon. Have a good day and have a wonderful rest of the week. Bye.